Good afternoon, everybody. I thank the organizers for giving me this opportunity. My topic is minimally invasive surgery in infertility. With the advances in instrumentation and technology, the approach to managing infertility has changed. In India, we have good hospitals, excellent accredited hospital, world-class facilities to deal with this condition. And we have expert laparoscopic surgeons, robotic surgeons who can handle these surgeries which would otherwise require a bigger incision with small keyhole methods. The traditional laparotomies are now a thing of the past. Now everything is done in a minimal invasive setting. You have only buttonholes and then you can look into the abdomen and treat in the same sitting. Then what is so good about this minimally invasive keyhole surgeries? You have smaller incisions, you have less pain, less blood loss, shorter hospital stay. Actually, patients can go home the same day after a few hours and they can return back to the normal activity. So when you say minimally invasive surgery, you can do it by laparoscopy or complex cases, the redo cases. We have seen many patients coming from different countries where surgery was already done, maybe a myomectomy or a ovarian cyst which was removed and then it has recurred, and then some people come with chronic pain abdomen, and difficult cases we would like to do it with a robo. What are the indications? When do you offer surgeries to infertile patients? One is unexplained infertility. Now you have seen the hormones are all good, they are ovulating, the male partner, the semen looks okay, and still the patient hasn't conceived over 1 year or 2 years, and then we can subject them for a laparoscopy where we go into the abdomen and have a look, and at the same time we can see and treat the condition. Some conditions like uterine conditions, like when a lady has a fibroid or any congenital uterine abnormalities or divisions in the uterus, what we call septum or bicornuate uterus. The tubal factors, the tubes which are the conduit for the picking up the egg from the ovaries, they may be distorted, they may be blocked, or the ovaries which produce the egg, either they don't produce the egg properly, this is polycystic ovary, or they have cysts or endometriosis, which is very common in infertile couples, what we call the chocolate cysts. In laparoscope, we put a telescope in the abdomen, as the previous speakers already said, and then we look at the uterus, looks normal or looks abnormal. The tubes, they look normal or abnormal, then the ovaries, and what is the relationship of the tube to the ovary. The tubo-ovarian relationship is important, that when the ovulation happens from the ovary, the tube has to pick it up. So the relationship where they should be located is important. And in the same sitting, we can put the blue dye, the methylene blue, through the cervix, see whether the tubes are open or not. If they are not, there are some methods available with fimbrioplasty. We open the fimbria, or the tubes are adherent to some structures that we can release it and again make the normal anatomy so that the patient can conceive on her own. At the other end, we find the tubes are very distorted sometimes, like a hydrosalpinx, that we may have to clip the tubes, that is disconnect the tubes from the uterus, so that when they go for a IVF, the success rate is better. Same time, we do a hysteroscopy, that is looking into the cavity of the uterus by using a distending medium like normal saline. We see the uterus inside the cavity of the uterus, the opening of the tubes, they are normal or not, whether there is any fibroid, any in the cavity which can be removed, or any septum which we do the resection in the same sitting, give her a normal uterus so that she can try on her own and become pregnant. Same time, if we see fibroids, we can remove it we can remove it by the minimally invasive method, do a myomectomy and give her a good uterus for which she can conceive again on her own. And in complicated procedures, as I said, like a frozen pelvis where we find no anatomy, it's all surgery done once or twice, and difficult cases we like to do with the robotic system. This is a high-end technology, and it is used where sometimes when laparoscopy becomes a little difficult, we can select those cases for robotic surgery. The advantage of robotic being the magnification and the instruments, which are like a surgeon's wrist. So when we operate from the console, we are fully in control, and our movements are transmitted to the robotic arm. And at the same time, the complex cases can be handled because how we use our wrist, the same movement can be done with the robotic instrument. And it is akin to doing a laparotomy, open surgery, but with very small holes. So advantages are many, the vision, the magnification, and it is better in obese patients when surgery becomes difficult both for the surgeon and for the patient, and then we can do it by a minimal invasive method. To conclude, I would say in infertile patients, endoscopy helps us in making a definite diagnosis. We know for sure whether she should conceive, or we give them a few trials, few months. If the patient doesn't, we refer them for further IVF. We correct treatment which is done in the same sitting, and we can plan a future strategy. In India, where we have the high class quality care, and we do it at much less cost than the Western world, and all facilities in a corporate setup are available under the same roof. So we do the surgery, we think she can conceive, wait for a while. If we think the chances are less, then we can refer them for IVF or any higher methods. And there is very little waiting time because we give priority to the patient, and with very less waiting time, we can complete the procedure for them and they go back. So thank you. I think they go back very happy and colorful. Thank you.